There was delayed crying. But apart from that, everything else was uneventful. She had 2 episodes of febrile UTI with seizures. And on examination, general examination was essentially unremarkable. Anal tone was lax, and there was decreased pain sensation over the lower limbs, decreased lower limb tone. Power was 2 on 5 at hip, and almost no power at the ankle. And spine was normal. Systemic examination was otherwise normal. Now, I would like to get the opinion of the panelists. In this kind of a scenario, what do you think is the role of maybe getting a bladder diary and anything more in history and examination? Dr. Hemanth?
Can you hear me? Yeah. See, 3-year-old baby, voiding diary is going to be difficult. We'll have to go by the history which the mother says about the number of voids, how much time she wets, and how much quantity she wets. Otherwise, to maintain a voiding diary, I don't know, in 3-year-old might be a bit difficult.
So, Dr. Ramesh, anything more you'd like to know from the history examination?
Basically, this is a patient who has had at least 2-3 episodes of urinary tract infection. I would like to know about the bowel habits, like how the child is constipated, whether the child has got any soiling. And sometimes these children have typical problems with the passing stools. They stand and pass stools. That kind of situation will give you an idea that they have a problem with the bladder bowel dysfunction. They don't sit and pass stools.
So she did have, she was not passing stools regularly, and she was having this fecal incontinence. So, Dr. Ganesh, any thoughts you would like to share?
No, I think I'd agree with Hemanth here. It's going to be impossible to get a voiding diary as such. But if the mother is able to tell us how many pads she's wetting, or if she's not available, if she's socioeconomically underprivileged, then how she's managing, how many times she's wetting whatever clothing she's wearing. Also, by looking at the child's perineum, you have a reasonable idea as to how much of leakage there is. There could be a lot of excoriation, a lot of skin rashes, etc. That itself would give us a good idea. On the rectal examination, you told us that the anal tone was lax. I would have liked to know actually whether there was any stool palpable in the rectum. I mean, some sort of a, they have fecal loading, and sometimes you can feel very soft stool in the rectum, and then this comes out as fecal incontinence. So just telling me anal tone is lax is not sufficient. I'd like to have known whether, especially when she's got encopresis, I just want to know whether there was stool impaction at the time.
So there was stool impaction, and yes, as Dr. Ganesh rightly said, it's good to make a note of that. So, Dr. Sujeet, in such a scenario, how would you go about the next step of evaluation? And you please share your thoughts in managing this child.
So, Chandra, good evening. Based on what you have said up to now, is the sacrum palpable as normal?
Yes, the sacrum was normally palpable.
The next thing I would do is that in a 3-year-old child, you should be able to make the child sit and see whether the child is able to walk at all or no. Is she dribbling continuously all the time? Because the maternal history quite often is fallacious and it can't be proved. So I would like to bring the child under observation and first see the actual voiding pattern and voiding stream. The frequency voiding chart will be feasible only if there is a ability to pass urine. Otherwise, the frequency chart or voiding depth followed by this observation, we have to make investigations.
Thank you. So, continuing on the frequency volume chart, at what stage would you say frequency volume chart is a mandatory evaluation? Because as the panelists rightly mentioned, it is not an easy thing to obtain a good number of children. So, at what age would we say that it is an essential thing they should ask for, or any other parameter you use, Dr. Sujeet?
So in our Indian scenario, bowel training in children is not actively done and largely passively acquired. 3 years and above, if the child is voiding normally, we should be able to get a frequency voiding chart done.
Okay. So I'll continue. This particular child, as we were discussing, this was a frequency volume chart that is obtained. Possibly this does not have much of a role in this particular management. Any comments by the panelists? I think I will mute others because there is some voice disturbance, right?
So I've just muted everyone. Now I'll unmute only the host.
I think we have some of the background disturbance.
Yes.
I will remove other. I will ask everyone to go come on Facebook only, sir.
Some baby is somebody's baby is I think joining the discussion. Is that right?
Yeah.
Yes, 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 yes.
Some babies there.
Yeah.
Better now,
Okay.
yeah.
Right. So this is the voiding diary that was obtained. So Dr. Ramesh, would you like to comment anything on this?
See, voiding diary is very important, particularly if the patient is above 5 or 6 years old. I mean, that is the time when they can actually measure it properly, and then they can tell you properly. And these parents, we have to sometimes insist on getting the voiding diary back, because they either don't write or they write and don't bring it. They said that I wrote everything, but I kept it home. This is really frustrating. You wrote everything. And so I make sure that they get the voiding diary, and then I see that because there is no way I can tell, how many proper emptying was there, so how many leaks were there. There are a lot of things I can get information from the voiding diary. So unless they get me the voiding diary, I don't actually even write any investigation or prescription. So that's very important for me to further, go further.
Yeah. So thank you for that. So do you have any practical tips, Dr. Sujeet, on the voiding diary? Because the container to measure and how to write, this is a voiding diary sheet that I have showed. So do you give any such inputs to your patient if they ask, how do I measure, what do I use? What would be your, I think Dr. Sujeet is muted.
No. So, am I audible? Am I audible?
I think Dr. Sujeet has 2 devices. I think that is why it is giving a feedback. So
Yes.
maybe if you can switch off one device, that would be helpful.
Switch off the phone.
Can you unmute that, please? I'm not able to unmute. Nitish?
Chandra.
Yes?
Chandra. Is there any problem?
I'm not able to unmute Dr. Sujeet.
Okay, just hold on. Can you continue with?
We'll carry on with the discussion.
Yeah, sure.
Discussion. You're
So in
Chandra,
this patient, can I tell what my next step would be?
Yes.
I mean, we've had a voiding diary. We've already examined the patient. There is fecal loading, as you said. We have to deal with the fecal loading before we do anything else. But after the fecal loading is sorted, as you have shown, I would need a urine routine on urine culture. I will need an ultrasound. And because of the 2 episodes of urinary tract infection, I would generally go for a DMSA scan and an MCU, like in any other UTI here also.
Okay. So ultrasound was essentially normal and there were no scars. And, MRI was done, which was also essentially normal.
Good. Yeah. So this is probably a non-neurological cause of this bladder problem. Maybe a bowel bladder dysfunction or one of those dysfunctional elimination syndromes. Is that right?
The thing is, this child has paraparesis, no? That grade 0 power.
Oh, yes.
So
we don't know the
aspects,
reason for that. What could be the reason for that? That's something which we need to look at. There is no history of transverse myelitis or anything else as well.
So this is a 3-year-old at the moment.
3-year-old.
So from birth, she has that, sensory and motor weakness with the lax anal tone and delayed crying, I said. So probably related to some kind of paraparesis related to birth asphyxia.
All right. Yeah.
So Dr. Ganesh, would you like to share your thoughts on further steps with this child?
Just a point on that voiding diary, Chandra. There is a remark that the child was crying.
Yes.
2 or 3 times the child was crying. Just to know whether during the crying episodes, was there actually leakage observed by the mother? This would indicate that there is, when the child cries, there's a rise in intra-abdominal pressure. And if there is leakage of urine at that time, would suggest that there is some degree of outflow weakness also additionally to whatever else neurological problem there may be. The other thing is that you do have urine outputs maximally about 50 cc, which for this 3-year-old child seems okay. I mean, the maximum bladder capacity is the best that we have is 50 cc. So they're just under, but that's the best we can get. So I think these are 2 parameters that we have here from whatever little we can make on this voiding diary. So the maximum bladder capacity in the conscious bladder capacity is 50 as far as this child is concerned.
So Dr. Hemanth, if I have to ask you, this child has got now, from what I showed, the episodes of UTI, culture is positive, ultrasound-wise kidneys are fine. We've got this paraparesis/paraplegia, lax anal tone with loaded sphincter, loaded colon, and encopresis. So would you proceed with the pressure flow studies at this point, or would you empirically start managing?
See, one thing is that the ultrasound has shown the kidneys, but what is the bladder capacity or the residue that is there?
Bladder capacity was reasonably okay, hardly any residue. About 70 ml is the bladder capacity.
Now the next investigation would be a urodynamics, but I would also concur with Dr. Ramesh Babu that we should also do a imaging MCU and also do a urodynamics.
Okay, MCU, there was no reflux, fairly smooth wall bladder.
So this is a 3-year-old child who is already doesn't have sensation.
Chandra sir, Sujeet sir have joined back, sir.
Oh, thank you. Welcome back, Dr. Sujeet.
Thank you.
So I think we should proceed with urodynamics,
Okay.
and that will give us a very good understanding about bladder, the EMG. I don't know what the role of EMG would be there, but we should go ahead with the pressure flow studies.
Thank you. So for that, I'll go back to Dr. Ganesh. What would you suggest, sir, in terms of the role of EMG in a child like this, where there is a paraparesis?
It would be difficult. I mean, to actually see where exactly the effect of the sphincter, because I think most of us in our clinical practice, and as Paul Abrams a couple of weeks back said, that he doesn't do EMG at all. He just does pressure flow with video. So if you've got a video, you can take away the EMG component itself at that time. And most of us who don't have videos do an MCU, and on that MCU you can have a reasonably good idea. So matching the two would be okay. The biggest problem in a child putting an EMG is that the child will be fidgety. Of course, you might have to do this under some form of sedation. So it's going to be difficult doing an EMG. So I would leave out an EMG in this patient. I'd go on clinical judgment, I'd go on the MCU and look at the urodynamics because the child has got incontinence, urodynamics is necessary. But I think it's important to make sure that the bowel is sort of reasonably cleared when you want to do this test. Otherwise, these lines get jammed in and you don't get good traces.
Thank you, sir. I see Dr. Shyam Joshi has joined through our Facebook page. Welcome, Dr. Shyam and our other faculty members. So if you have a few thoughts or concerns or questions, please add it to the chat so that I can share with the faculty. Now, coming back to Professor Sujeet, how would you go about in terms of managing this child, Dr. Sujeet?
So, coming back to this child's urodynamic study, I missed a part of the investigation in the middle before the urodynamics.
MRI was normal, ultrasound no hydrated nephrosis. ECG was normal, no scars.
Right. So can I see the MCU picture, please?
MCU, we don't have a pictures, but essentially a normal study, which was done documented in the report as a part of the video aerodynamics.
Right. So in a 3-year-old child with an entirely normal spine, the MCU picture is important to see here on the film because the report of so-called normal bladder with no reflux, if it shows any abnormal dilatation of the posterior urethra, that will fit in the diagnosis of dysfunctional voiding, which is the commonest scenario in a 3-year-old child with this kind of imaging and this kind of urodynamic study. The EMG associated with this kind of a CMG would have clinched the diagnosis. But because the CMG has not been done and because we don't have video euro here, the diagnosis will remain uncertain. But the clinical diagnosis based on what you have told will be dysfunctional voiding. And the first step in the management is the bladder and bowel training with a mild dose of anticholinergic.
Thank you. So going to the anticholinergic at this age, how would you prefer XL or regular, or would you suggest powder, or how do you treat? Because that is a common question among trainees and those who start treating. How would you do in your practice?
So Chandra, in a child, the first thing around oxybutynin is the dosage of the oxybutynin. And it is very common to see underdosing of oxybutynin. So among the modalities of administration, we have oral and intravesical. The intravesical instillation of oxybutynin is purely an experimental therapy, which is not popular and doesn't have a predictable response. So we are left with oral administration of oxybutynin. Number 2, oxybutynin is not commonly available in India in a syrup formulation. So we are dependent on the tablet formulation. And we have 2.5 and 5 milligram tablets commonly available. So if you consider the dose of oxybutynin as 0.1 to 0.6 milligram per kilogram per day, then generally easy to remember is 0.5 milligram per kilogram per day. So simplifying it further, if a child's weight is 20 kilos, then the dose for oxybutynin is half of the body weight, which is 10 milligram, to be given in 3 divided doses preferably. So which means the starting dose in such a child orally would be 2.5 milligram 3 times a day. Sometimes that can lead to a lot of side effects, particularly in our hot summer months. So we would practically start with 2.5 milligram BD in a 20 kilo child, which is the common setting of 3 to 4 years of age. And then work on the bowel and the bladder habits for a few months before moving to the next step.
Thank you. So Dr. Ganesh, there is one comment from our Facebook page by Dr. Mudit Maheshwari. Since patient is having lower weakness, still dysfunctional voiding will be the first diagnosis? That is a question. What would be your comment on that?
Well, in the absence of any obvious spinal deformity on the MRI, And with the history that you've told us that there was some birth asphyxia, we have at the moment to assume that that is what has resulted in some degree of spinal cord ischemia, and what we are seeing now is the end result of that in terms of paraparesis. So, I mean, if there was something obvious as a cause for a paraparesis, it would have been evident on the MRI by now. And since it's absolutely normal, we just have to presume that this has happened. And since they say it was birth and that's a history, we have to accept it. So I don't think there's anything more you can do about it. She's got paraparesis, and with that power, we have to then work with physio and everybody else, a multidisciplinary effort to see whether she can have some degree of mobility.
Thank you. So, Dr. Ramesh, what would be your graded approach in terms of the bowel management in a child like this? Because as I mentioned, it was a lax stone, and then there was a loaded colon. We start with the oral stool softness. Do you have an algorithm in terms of the bowel management?
Yeah, before even I start this anticholinergic or any other bladder medication, I want to make sure that the bowel is absolutely, normal to condition, brought back to the normal condition. So starting simple laxative like a lactulose may not be enough. So I will aggressively give bowel washes rather than enemas. I would give a proper bowel wash by a trained nurse, and then empty the bowel first from the bottom end. Maybe we may have to give the peg move or one of those peg-like powders to start from the oral end and clear the bowel completely. That probably will take 2-3 days. Then I will put the child on a lactulose, that is to continue the maintenance. And then I will also intermittently use the peg move powder or one of those powders, whatever, like Easelac or something, at least on the weekends, to make sure that that constipation problem is not there anymore. And after that only, I'll start the child on oxybutynin. Like Dr. Sujeet said, I'll probably start with 2.5 milligram twice a day, maybe go up to thrice a day, and then increase it as the child tolerates it.
So there was one question from the Facebook page, whether the urodynamics was done under sedation. No, it was not done under sedation, but it's just that the child did not void when we expected the child to void. That is why we did not comment on the voiding phase. Thank you, Dr. Virendra. Thank you for joining us. Now, coming back to Dr. Ramesh Babu again, is your management any different in terms of the bowel in children who have very lax sphincters like this versus those who have a reasonably normal sphincter when you're talking about bowel wash and enemas?
The sphincter laxity, it does not alter the management of my bowel, because I want the bowel to be empty. Even in those who had various pull-through operations and the sphincter is lax, if the bowel is empty, they are continent. So we need to keep sure that the bowel is empty, whether the sphincter is lax or not. So it doesn't alter my management.
Dr. Sujeet, there's a question on the Facebook page. Is there a role of interstim and neuromodulation in this age group? What would be your opinion?
So there is a role for that, but not as a starting therapy in all these children. See, Chandra, this baby is classically the bladder and the bowel behavior is linked to the perinatal hypoxia unless proven otherwise. So it is not the classical dysfunctional voiding that we discuss. It is probably a differential diagnosis number 2 is early neurogenic bladder because of perinatal hypoxia. Sacral neuromodulation is a treatment option, but if the child responds to good bowel management and mild anticholinergics, then sacral neuromodulation may not be necessary once the bowel is emptied adequately.
Thank you. So I would have a last question to Dr. Hemanth, but before that, I would just take a question from the Facebook page in terms of the role of Bristol stool chart. I feel Bristol stool chart has an important role in terms of bowel bladder dysfunction, which occurs in older toilet-trained children. Here, because we start with an evident bowel dysfunction with intractable constipation, maybe in terms of further management, there may be a role, but not in terms of the initial diagnosis and management. So Dr. Hemanth, what is your opinion on CIC in this particular child? Would you advise or how would you proceed?
Yeah, actually, I don't know. We have not discussed the urodynamic, whatever the chart you have displayed on the screen. So you want to discuss the urodynamic tracings, or
yes,
you want just?
You may please do that.
Yeah, see the urodynamic, because the postgraduates are also there. So I
yes, please do.
Discuss the urodynamic tracing also. As you see here, that there are intermittent rise in the detrusor pressure, which is also quite significant during the filling phase. That's the reason. So the filling phase is definitely unstable, which is one of the factors for affecting the compliance. So, adding to the previous discussion, we should continue with the antimuscarinics and also start with the CIC.
Dr. Ganesh, would you like to add anything more on the management before we go to the next case?
Just to add to what Hemanth has said, I see that the detrusor pressures when the child is being filled are quite high, and I don't see any leak on the flow rate. Is that right?
Sorry, I couldn't hear you. Yeah,
there was no leak. There was no leak. There was no leak. Was there any leak noticed at these high detrusor pressures?
There was no leak. There was no leak along with these documented overactivity.
That is a worrying thing for me, because these are, as Hemanth said, pretty high detrusor pressures, and with that, one would expect that in a child like this there would be leak.
So no, actually, it's marked in the top. In the top chart, there is a point. Second and third thing, leak point is marked there. I don't know whether they have marked it or.
I don't know whether it's a leak there or because the flow rate is not the floor is not showing anything. There's nothing squiggle, no squiggle on the flow rate. So I don't know what that is. But why I'm pointing this out is that I would be very careful when I look at this trace and find that there is no leak in a 3-year-old child. So is there actually a distal sphincter problem associated? And this is a child who could have problems in the future if we sort of just say this is detrusor overactivity or neurogenic detrusor overactivity. So I would be wary of this because there's no leak. And why is this child incontinent then is the question. Is it overflow? We don't know the bladder. How much is the capacity filled on the CMG?
It was up to 80.
Because you said the MCU was quite normal.
Yes, MCU was normal.
And we don't know what the capacity of the bladder was. 80 cc? 100?
Up to 80 it was filled.
And how much was there at the end of all this? Did we sort of check it out after all these leakage?
About 30 to 40 even initially also, the ultrasound it was not like a lot of urine that was being retained.
The other thing is that the child have sensation of voiding. It's 3. The baby is 3. The kid is only 3 years old.
Yes.
Does she appreciate bladder filling? Because it'd be very difficult for a 3-year-old child to sort of know whether her bladder is full or not. It takes a little older child to know that.
So it was not commented.
Chandra, can I come in?
Yes, Dr. Sujeet.
Sir, actually, if you look in this child, look at the frequency voiding chart that was shown, corroborated with the MCU and then corroborated with the urodynamics that has been shown. It actually classically demonstrates that the frequency voiding chart does not really tally with the urodynamic investigation unless the urodynamics has been done in a sedated child.
This child was not sedated. Yeah.
So if you go back to the frequency voiding chart, you will see that this baby is voiding 5 mil, 10 mil, 15 mil. And that is why your first question at the beginning of the discussion was very pertinent as to how has this frequency voiding chart been recorded. Because as Professor Gopalakrishnan was mentioning, if you look at the urodynamics, the pressure is rising without any leak, which is a story completely different than what was reported by the mother and recorded in a frequency voiding chart. Point number 2, that we first start a small dose of anticholinergic for a few days for the child and the parents to lose the fear of treatment and invasive treatment. Then we go on to bowel wash over the next 2-3 weeks. And then if the child is still dribbling or not passing urine in stream, CIC must be started, because we have to not allow this child to go on with an obstructive lesion, which may be in the area of the bladder neck and the posterior urethra, because with these pressures are very high, and if they don't quickly respond and they are not bypassed by way of CIC, treatment will remain incomplete.
Thank you. Thank you for that opinion. There was a question from here, how feasible it would be for parents to do CIC in a 3-year-old. I would say that it is a commitment from the side of the treating pediatric urologist and maybe a urodynamic nurse and the parents to teach them the importance of that, because the long-term consequences would be much more severe if this child is not managed completely at this point in time. Would you agree with that, Dr. Ganesh?
Yes, I think the child, I mean, we need to have somebody who's committed to teaching this child, and it is highly possible. It's possible. The other thing that I do is I have videos of children and I show it to another child, saying that, see, look at this kid is doing the CIC, you can do it. And we have, as you say, a dedicated nurse and with the mother, and it takes a little while, it takes a bit of cajoling, but the advantage is this is a girl, and girls are easier to handle than actually boys when it comes to CIC. So I would say that yes, it's possible to do CIC for a 3-year-old with commitment. So
I think
that a 3-year-old therefore it will not happen unless you do it. You won't know what is going to happen at all, and I can come on ultimately.
Thank you, Dr. Ganesh. I would like one last question to Dr. Sujeet before I go to the next case. Why we prefer oxybutynin over other anticholinergics is a question from Dr. Prakash. Would you like to take that before I go to the next case?
So the answer to that is the safety, effectivity, wide availability, and the cost, all 4 factors. This has been the drug which has been around for 40 years, right from the time of Alan Maguire. It has produced excellent results without any serious side effect. It is tolerated very well by children and is widely available with very acceptable pricing. I don't see any role for any newer anticholinergics, excepting the beta-3 agonist, which is having some emerging role. Not very convincing yet, but it is appearing in the horizon as a drug which can be used before we label the child as failed to a trial of anticholinergic to move to the next step of treatment.
Thank you. Dr. Hemanth has a point to make, and we'll go to the next case after that.
Another advantage of oxybutynin is you can escalate the dose.
Okay, right.
Unlike tolterodine, which comes in 0.2, 0.4, but dosing is safe to escalate the dose in oxybutynin.
Thank you, sir.
Chandra,
Yes,
just to, since this is there's a lot of residents and postgraduates, there is data, there is evidence that solifenacin, the M3 blocker, at least solifenacin has been shown to be useful in children. There are studies for this. So don't throw it out of the I know it's expensive drug, but I have used it.
Okay.
I have used it. 5 milligrams of solifenacin, I've used it in this age group. And that's after looking at all the data, and there is publication to that effect. So although oxybutynin is time honored, I think sometimes you may find difficulty with one drug, you may use the other. So I think that question which whoever raised was pertinent as to why one or the other. So correct me if I'm wrong, but I certainly have used solifenacin 5 mg without any problem.
Chandra, I just want to add one point.
Yes.
Yeah. So one of the advantage I find with oxybutynin is this 2.5 milligram tablet, which is, very easily breakable. Just half tablet is possible. 1 tablet is possible. Whereas when we go to tolterodine and solifenacin, I don't mind using them in a 50 kilo child or a 25 kilo child. But for a 10 kilo child, titrating the dose of that is very difficult.
Okay.
You know what I mean? the tablet has to be broken into 4 or 5 parts, and then somebody has to make it up for them.
Thank you. So I think I will move over to the next case. Are you able to see my screen?
It's not moving.
Not
I'm
moving.
sorry. Yes, so I'm unable to see myself too.
Maybe you should stop sharing and then restart sharing. Yeah, case 2 is the now one.
So this is a 13-year-old boy with no comorbid illnesses, and it was a short history of loss of sensation of both lower limbs and inability to walk for 4 days, and continuous urinary incontinence and unable to void, had not passed stool for 4 days, and he was catheterized elsewhere, and 1 liter of urine was drained. And prior to that, he had a history of high-grade fever with no localizing symptoms 2 weeks ago. In general examination, unremarkable. Abdomen was fine, and he had a 12 French catheter in situ. Anal tone was lax. Bulbocavernous reflux was absent, and there was decreased sensation below T8 dermatome. Lower limb again, tone was hypotonic, 0/5 power. Reflexes were absent. Spine was normal. Systemic examination otherwise unremarkable. And investigation, bloods were essentially normal, and ultrasound shows kidneys were normal. So going to Dr. Hemanth, how would you proceed with this child?
See, presently he has presented in the first week of the urinary symptoms. Am I right?
Yeah, he came with the catheter because he developed retention.
Yeah. But so basically, going by the history, whatever the etiology, probably a myelitis, transverse myelitis, could be one of the reasons for the presentation. And so presently he is in a state of spinal shock, where there is no power in the lower limbs, anal tone is lax, bladder was palpable. So it's just decompressing the bladder, keeping an indwelling catheter for a certain period of time till he recovers.
Okay. So how would you proceed from here, Dr. Hemanth?
Yeah, so you have shown us the investigations, the upper tracts are normal. So
Yes.
I think we are in the first week of his admission now when he presented.
Yes.
So, as long as he's in the hospital and before we finalize, the first part is managing his myelitis, the transverse myelitis. That would be one part of the management, which the concerned specialty will go ahead with steroids. And as far as the urinary tract management, he'll be on an indwelling catheter till we reach his acute treatment, finish his acute treatment.
So, Dr. Ganesh, how would you counsel the parents? Because evidently they are anxious because sudden onset with neuromuscular deficits as well as the bladder dysfunction.
Well, as Hemanth said, that this is like a spinal shock that has happened to this boy for 13 years old. The only thing is, when he had this 1 liter, was it a painless one, or was he actually? It looks as though it must have been painless retention, must have been slowly filling up. And what I would do is tell the parents that this is a situation where we don't know whether it's going to be reversed completely, and this will take some time, depending on what the cause for this problem is. Is it a myelitis? Is it a demyelinating condition? Is it related to the fever? Something obviously has happened, the fever, and then bang on something like this has happened. So the pediatric neurologist or the neurologist will probably evaluate this boy and do all the fancy tests and maybe intrathecal medications to see whether he can recover. But I would tell the parents that we've got to wait for a minimum of 4 to 6 weeks to see whether he gets back. If he gets back any sensation at all, one of the things that might happen is he may start beginning to feel the bladder. He may start bypassing the catheter. These are things that could happen, and we need to be careful for this period of time and keep him on drainage. Hemanth says catheter drainage, fine. The only thing is we need to put a reasonable smaller size catheter because he's a 13-year-old boy. We don't want to have him to get epididymitis and all the other things consequent to long-standing catheter. But give it enough time to see whether there's a chance for recoverability of the lesion, and then take it from there with bladder evaluation.
So coming to the catheter size, Dr. Ramesh, in this 13-year-old, what would be the choice of your catheter?
Yeah, I want to add a point from what Dr. Ganesh sir has said. We do not know how long this boy is going to need a catheter. It's a bit like the end date of a corona. We can never say it may be 1 month, 2 months, 3 months. So I do not know how long he will need an indwelling catheter and whether it is wise to have an indwelling catheter for 6 months. Number one.
Oh.
Number two, number two is if I want to do a trial voiding, if I have an SPC, it's better. So I probably will see they usually are in ICU, and then I see them, while they are in the acute phase, I ask my radiologist to put in an SPC instead, so that I can clamp it and see for a trial voiding as he starts going home. So that will be my approach, because we do not know with the Foley's catheter. Obviously, you have to take it out, reinsert, take it out, reinsert. It's quite traumatic in a child. So I'll put an SPC in this child probably within 5 days. About the size of the catheter, probably the smallest catheter, at 10 French or 12 French is probably the best.
So I have a question for those who can give their opinion on Facebook or through a Zoom page. How many of you would go for a silicone catheter, and how many of you would go for Foley's rubber catheter based on your present practice? Silicone. I'm just giving an opinion on your present practice. Please share us your chat message. Have you been putting silicone catheters or rubber catheters? So you can send your message as an SMS in the either on the Facebook page or in the Zoom chat. Please share your thoughts. And we'll continue. This was the pressure flow studies that was done. And Dr. Sujeet, would you like to comment on this pressure flow studies?
So Chandra, I'm not able to see this very clearly because I'm on the phone.
Okay, sir. Sure, okay. Maybe I can request Dr. Ganesh to please give your opinion.
Paediatrics. Looks like a bladder